I'd like to introduce Dr. Matthew Zinn. Dr. Zinn is an assistant professor of pediatrics, as well as being a heart transplant physician. He's a medical director of both our ventricular assist device program, as well as Dr. Bill Natchez Heart Camp for Kids. The title of this talk is Inotropy, Ventricular Assist Device, and Mechanical Circulatory Support.
All right, thank you, Sean.
Inotropy.
Thanks to the organizers for inviting me here today. There we go. Okay. So Dr. Saroff set this up very nicely. We have medical options that we have in place that can treat our forms of Fontan failure. But once those fail or no longer effective, then we've reached our end game, right? There are only a few things left that we have to do in order to get us to that ultimate goal of transplantation. But before we figure out what we are going to do, we have to figure out the exact type of Fontan failure. There are several types. The ones that we will focus on today, because they are directly applicable to our MCS conversation, would be type 1, so systolic dysfunction, and type 3, which is the failure of the Fontan circulation. And then there are, of course, there are types of failure that have all of that together. So that'll be the mixed type, to where the response will be a mixed response. So just to look at, we've talked about this and looked at this in various ways throughout all the other talks, but one large study out recently of 173 adult Fontans showed that 28% exhibited signs of Fontan failure, all different types of failure, at around a median of 20 years after their Fontan operation. And I think this graph nicely shows under A, you can see the green, which is all preserved ejection fraction, and then the pink and the blue are your types of dysfunction that are small, but over time, going from that around 3-year follow-up to around 22-year follow-up, the degree, of systolic dysfunction in the pink and diastolic in the blue significantly increases. So as we've seen in other talks, over all of the hemodynamic changes that occur over the years, the systolic and diastolic dysfunction develops over time, as due to a smaller degree increases in PVR. That's important because the type of failure determines how we are going to respond from a mechanical support standpoint. If we look at our systolic dysfunction, right, those patients will have elevated end diastolic pressure and a low transpulmonary gradient. So this is the impaired cardiac output phase. And then the failure of Fontan circulation, higher than normal CVP. We know that's higher already in Fontans, but at least here over 15, a normal end diastolic pressure, so filling pressures on the ventricle are okay. Elevated transpulmonary gradient, I've seen that number anywhere from over 7 to, for us in other areas of transplant, over 15. These patients have volume overload, pulmonary hypertension. All of this leads to that group of symptoms that we've been talking about that leads to decreased pulmonary blood flow. So our approach to these two types of failure guides our MCS strategy. But first, we need to know what is the goal. Right, we've heard a lot about all the different comorbidities that can come along with a Fontan patient over time. So not everybody is going to be a transplant candidate. There will be a complex evaluation that we go through from a VAD and a transplant standpoint that will either rule people in or rule them out. We can always do medical management on either side. We can also do destination therapy on the side where you're not a candidate. And then based on the age, size, multiple different factors of the patient, that guides our MCS decision. The listing will also be different. In pediatrics, we are still on the older system for listing in UNOS. So every VAD, no matter where you are or how sick you are or if you're at school, will be a status 1A. Whereas in the adult world, now the Fontans with a VAD would be a status 2. And then the congenital heart disease alone, so the Fontan patients without support, would be a 4. So the waiting time is drastically different amongst that, which is why we always try to get to people pre-18 so we can list them on the pediatric strategy if possible. Again, as Dr. Saroff talked about, we would still employ all of our goal-directed medical therapy in anticipation of the eventual need for MCS. And we like to be involved early. This has been brought up a couple times throughout the day so far, to where as a patient starts to show signs of failure, it's good to get us involved as early as possible so we can help guide and make these decisions as a team about ultimately getting someone to a VAD or a transplant candidacy. That initial study that I showed in the adults, at that 20-year mark, those that have already started to develop or to show signs of failure, the freedom from death or transplant 5 years later is 70% and only 40% 10 years later. So we can see that once failure sets in, it moves. So we like to be involved as early as possible to help. Part one of my assignment for this was to talk about milrinone. We know the effects of milrinone. I've listed them on the screen. It can be, it's a very effective inotrope, one of our favorites in the pediatric ICU. Although it works differently, right? Milrinone doesn't respond the same way that it would in cardiomyopathy. We have seen in a study that looked specifically at the way the downstream molecular signaling of the phosphodiesterase inhibition works, it's different. So here, it's not so much that we are changing the calcium regulation. It's more so probably that lowering the SVR, decreasing afterload allows for improved function of the ventricle. But as we saw in the last talk, we can't expect that the drugs that we use in biventricular physiology will work the same in a failing Fontan. Dopamine, again, in our pediatric guidelines, would be there as well. It can be another first-line agent, but it doesn't have the same effects, clearly, we all know from milrinone. And then epinephrine is more of the second stage, where specifically if we are hypotensive. From an ECMO standpoint, it is, of course, on the table when needed in an acute event. In talking with our surgeons, our cannulation strategy typically in this size patient would be through the groin. And then we would add additional cannulae as needed to increase our venous flow. But of course, patients with all single ventricle physiology are ECMO candidates there, but they are of a varying degree of quality. We know that stage 3, so in this category, have the best outcomes, where the outcomes of ECMO at stage 1 or stage 2 are quite inferior. But they're still not good. They're not equal to our general congenital heart disease numbers. We can see here 230 Fontans, only 35% of them survived a discharge. And in another study, only single center, they had a very low incidence of ECMO after Fontan, but again, a low number of them survived to discharge. Compare that to our current numbers at the Children's Hospital of Pittsburgh in the extracorporeal life support network. We have our pediatric cardiac ECMO has a 61% survival to discharge. And of that, it's just the closest thing I could find. The hypoplastic left heart syndrome patients have a 57% survival, and that number is up into the 70s for our neonates. So it is improving, and as we get better and better at ECMO, these numbers will go up, but they will still be limited compared to our other means of support, and that's our ventricular assist devices. Again, devices that were not designed for use in single ventricles, that we have come to use at increasing frequencies, but still things that are used in relative infrequency compared to the rest of the indications. Looking at our two big databases that we have now, PDMAX, which is our pediatric version of Intermax, congenital heart disease actually it's increasing. Now about 25% of the VAD patients that we have in the registry are due to congenital heart disease, not just, we're moving away from that almost always just doing in the cardiomyopathies, normal biventricular anatomy. We do know compared to non-CHD patients, higher mortality, lower percent transplanted at 6 months, but interestingly, no difference between biventricular anatomy or single ventricular anatomy. So having a single ventricle is not a contraindication on its face to doing a ventricular assist device. That's a much bigger evaluation. But looking more specifically at the type of single ventricle support, the Fontans do the best. We have, in that report, there was 95% survival at a year after implant. The next one is Action. For those who don't know, Action is our pediatric VAD learning network run out of Cincinnati Children's. We were a part of this report that talked about 45 patients with the Fontan, all under 18, average age of 10, mostly with RVs and moderate to severe AV valve regurg. They had roughly an 80% bridge to transplant or still on support rate, which is pretty similar to patients, or all patients on a VAD. So when we look at just our Fontan patients alone, the outcome of VADs is actually pretty good. Compare that just in an incidence point to the adult with congenital heart disease. There wasn't much out there about using adult or this type of support strictly in an adult population, but one pediatric group looked at the UNOS database and simply showed that ACHD patients receive VADs at a pretty low rate, only 10% of them, but that actually seems up. I looked at some studies from around 2015, and the incidence was less than 1%. So that number seems to be rising, just in general, like with us in peds, that as we get better at managing these devices, the numbers will increase. So what options do we have? Our options, again, are all designed for a biventricular anatomy. And now in pediatrics, because nothing is, other than one or two pumps, nothing is specifically designed for our small patients. General rule, over 25 kilos, we can use our HeartMate 3, the standard intracorporeal device in adults. Under 25 kilos, we think about our Berlin X-Core, our Centramag, and then we've started to see a little more use, not much, of the Impella 5.5 as a temporary support when needed. If possible, from a device standpoint, we prefer to use continuous flow devices. If we put a pulsatile device in any patient, but in a Fontan, it will only decompress and drain the ventricle in diastole. If you have a continuous flow device, it is continuously decompressing the ventricle, and we have seen that decreases that reversal of flow into the pulmonary veins, decreases your pulmonary edema. So when possible, just like we like to do in all cases, use continuous flow devices if possible, but any of our devices have been shown successful as a bridge to transplant. From an implant strategy standpoint, we won't spend a lot of time on the surgical aspect. There are centers that prefer atrial cannulation, ventricular cannulation. We've heard a lot from other talks about the other anatomical considerations. The thing specifically for us is if from a space standpoint or trabeculations, you can either remove those trabeculations as we saw in some of those echoes, or we can outright just remove the AV valve, whatever it takes to get the pump in there and to work as best as possible. And then other centers have described wrapping the device or essentially preparing the device or the patient at the VAD time for the ultimate transplant to expedite the transplant. We've heard a little bit as well about hypoxemia. So the fenestration and the veno-venous collaterals, there again are some people who recommend doing the fenestration all the time, others where it's questionable or they do it case by case. Veno-venous collaterals on that pre-VAD cath, do we close big ones, close them, or go back and close them after if there is ongoing hypoxemia? Now, the most interesting part here, AP collaterals. These are, in our VAD flow, right, these are our enemies, right? They will take, on an estimate, 20 to 50% of that cardiac output right back to the ventricle and maintain an ongoing volume load. So we have to set our VAD settings, our RPMs or our rate, at a much higher level than would be expected in order to account for this, so we ensure that we have adequate cardiac output. There's not much specifically in terms of difference, really, or dedicated therapies right now in terms of supporting the failure of Fontan circulation. We can still use milrinone. This hopefully decrease our PVR, increase our cardiac output, but short term. Milrinone is not something we're going to put someone on for months and months and months and send them home. If we have a short period of time per transplant, then we can consider doing that. ECMO, of course, can be used. And in this case, though, the systemic VADs, the things we just talked about, aren't really going to help. If we have someone who primarily has a failure of Fontan circulation, the systemic VAD is not the answer. Subpulmonary devices have been used and have shown success where we cannulate the cavo pulmonary anastomosis, and then cannulate back into the pulmonary artery, whether it be with a pulsatile device or with a continuous flow device. As Dr. Kreutzer alluded to in the morning, what I think is the most exciting part is that there is development of Fontan-dedicated devices. This is difficult, as with all device development based on funding. These are all dedicated, or specific investigators are pushing these now. All are implanted directly into the Fontan circulation and have been shown to improve cardiac output, lower CVP, and can support the circulation directly. But these right now a couple of these are all over the world, and they are still in development. One that has been actually used in people already is the Berlin X-Core venous cannula. This is very cool because the system to do this already exists. This is just a new cannula for our Berlin system. It basically takes the place, right? You connect the IVC and the SVC to it, comes out to the pump, and goes back into the pulmonary artery. This has been shown successful in the Berlin group in a 12-year-old and a 17-year-old. I think it seems that this will be the thing that has the most immediate potential for us because it really is just a new cannula and a system that already exists. In a mixed etiology, we just combine the two things that we just talked about. We can do a VAD in the systemic position, milrinone on the right. We can do BiVADs, or total artificial hearts have also been shown to be effective at this stage as well. And we'll close just with our experience. In the past 10 years, we've had 4 patients at this stage who have been supported. Our smallest was a 3-year-old who was successfully transplanted after about 53 days off of Berlin. Then the next 2 were transplanted off an HVAD, which for us is very sad that is no longer available because that was our perfect right around 20 kilo pump that worked really well for us. They were both successfully transplanted as well. And then finally, our most recent patient was an 18-year-old who was supported with an Impella 5.5 for almost 50 days. So this was one where we were on the bridge of the supporting from a ped side to the adult side, and talked with our adult colleagues, thought we would support this person for around 2 weeks. It ended up being around 7 weeks. And then in talking with the company, this is still the longest support of a single ventricle with an Impella 5.5. So in the end, there are medical options, there are mechanical support options, but each one needs to be tailored specifically to the patient, their exact type of failure and the goals of care. But it's not without risk. There are significant morbidity and mortality on the wait list, but they are superior to earlier stages. And ultimately, as we'll hear in the upcoming talks, transplant is the final end game for everybody. Thank you.